have the last case presentation by Dr. Sonali.
How many of the audience present here perform Botox injections or fillers or even blepharoplasty surgeries? Can we have a show of hands?
I think everyone nowadays.
Yes.
In India, cosmetic
so
surgery has become very
thing.
common. And I feel all the oculoplasty surgeons today doing both cosmetic, functional, everything, oncology, everything has become like, it has become a huge load for all the oculoplasty specialties.
Ma'am, I would like to add from Adit's talk here. I mean, we all know that, you know, an eye surgeon or an oculoplastic surgeon understands the ocular anatomy better. So we have seen this, you know, the plastic surgeons doing, and most of the time they'll end up with an antidelamellar retraction, lower eyelid retraction, or an entropion. So I think that message should go very, very clear. Despite this, you know, most of the patients reaches. It's just that the patient doesn't know where to go, approach, and which surgeon to approach for blepharoplasty. So the message is so very clear that in and around the eye, these surgeries has to be done by an oculoplastic surgeon.
I think 5-10 more years and we are just 5 years behind the West. We are accelerating towards that goal.
Actually, in India, still today the guideline is not there. The face belongs to whom? Whether it belongs to a plastic surgeon, whether it belongs to the eye surgeons or the maxillofacial surgeon or ENT surgeon. NMC has given a recognition to the MDS, like the face belongs to the MDS. So now we should also try that, we should make NMC realize that face actually belongs to the eye surgeon because the main modulus of all the muscle, it is in the upper part of the face.
Totally agree, ma'am.
Pardon?
Yes. Dermatologists.
Yeah, dermatologists, but they are not doing the surgery.
No, they are doing some.
Now they are doing the surgeries.
Yeah.
Dermatologists, blepharoplasty.
And Dr. Assam, what my experience in Middle East, so there are surgeons who just call it as eyelid trimming. They don't even call it as, right, in Egypt and Middle East. There are so many people, they don't correct the ptosis, nothing. They just tell it's eyelid skin trimming. It's called not even blepharoplasty, and it's so common, yeah.
Actually, most of non-oculoplastic done procedures are just removing strip of the skin and resuturing back.
Over to you, Dr. Sonali.
Good morning, everyone, the esteemed faculty and all the seniors. I'll be presenting a non-surgical way of rejuvenating the sunken superior sulcus with hyaluronic acid fillers. So, as we can see on the right side, we have a very young Asian woman, and on the left we see an older Asian woman, both beautiful in their own ways. But there are differences between the two. In the upper face, we see the forehead wrinkles in the older woman with a deep superior sulcus, excessive eyelid drooping, and mid-face ptosis and lower face sagging. So the pathogenesis of sunken superior sulcus is multifactorial with disproportion between a prominent orbital bony framework and underdeveloped soft tissues, trauma, and excessive fat removal after blepharoplasty with senile changes. The senile changes are the commonest one, with signs showing hollowing of a volume depleted sunken orbit, loss of eyelid crease with deflation of the upper eyelid due to soft tissue changes, and the bony changes when there's resorption of the bony rim leading to a skeletonized orbit look. So the main cause is volume depletion. So how do we go about treating it? There are surgical and non-surgical options, with non-surgical ones being preferred by the patients and by the doctors as well, as they're easy to perform and OPD-based procedures. Now, until recently, the surgical structural fat injection was done, but even though being a gold standard procedure, it is an invasive procedure with associated fairly significant morbidities like visible lumpiness, swelling, bruising, and poor acceptance by the patients. So rejuvenation of the deep superior sulcus in the eyelid with a non-surgical volume rejuvenation with hyaluronic acid filler is an effective way of a non-surgical therapy. So the technique includes, so this animation shows the use of a cannula First, we clean the face, the area where we are supposed to inject. As we can see, we pierce it with a needle, and then there is a placement of the hyaluronic acid fillers, which smoothens the skin and evens the overall surface. So as you see over here, on the right side, we see a 50-year-old female who came with an A-frame deformity of the deep superior sulcus. And post the filler injection, as you can see, there is a fullness and an overall even surface. So the technique here we see is after marking of the desired area of the superior orbit, there is an initial entry tract is created laterally near the lateral orbital rim with a 24 gauge needle. And as you see, the use of the cannula is safer in avoiding any of the injury to any important structures. And while we are doing it,
Yeah, go to the next slide, I think.
Yeah, okay. So, the results of the superior sulcus deformity will be depending upon the grades of the superior sulcus. You can grade it with grade 1 being 0.5 centimeters or less, and grade 2 being 0.5 to 1, grade 3 being 1 centimeter or more deeper, and grade 4 will be a sunken depth of more than 1 centimeters with blepharotosis. Now, as you see here, we see a 55-year-old female with a pre-dermal fat injection. As you see how deep the superior sulcus is, and post the filler injection, there is a fullness and an overall evening of the surface with a very good lid crease. So, these are the prominent changes that you see immediately. Another case of a 60-year-old female of the Northeast Asian origin with hollowing around the eyes, tired facial appearance, saggy appearance around the eyelids, the typical aging changes with the A-face deformity. Again, we are going ahead with the cannula and molding the filler as we do it, because it's extremely important to avoid the lumpy look, and we always inject while coming out so that we prevent any damage to any important structure. So this is immediately post the filler injection. You see the immediate change in the upper lid crease and how well it looks after a few days of downtime. This is immediately post and pre. So Frick et al. Investigated the efficacy of a lumbrical fat graft, Magnelia with a perosteal flap, Sizzy with a dermis fat graft, and a septal fat pad implantation. So all of these come with their donor site morbidity, not easily moldable because of the fat injection, the graft hypertrophy, they're not completely reversible, and there is also a risk of injection. So in our cases, usually we go ahead with an intraseptal or a retroseptal, a subdermal, or a preperosteal. But we have used the preseptal plane, which is usually the avascular plane. It is a better plane for the filler placement and helps avoid dreaded complications of intravascular injection. It creating an initial entry tract followed by the use of a blunt tip cannula provides an additional advantage to prevent multiple entry points, which further increases the recovery period. And although it is a controversial thing, a retrograde and resistance-free injection is the most key feature for safe and long-lasting results. So in conclusion, a corrective procedure for the superior sulcus is possible by a non-surgical way to corresponding to each grade with a satisfactory result. And hyaluronic acid fillers, they provide a safe and versatile non-surgical method for rejuvenation of the sunken superior sulcus. And reversibility is always the key, which is why patients are very happy with the hyaluronic acid fillers. So, thank you.
Thank you, Sonali, for such a crisp presentation. And this brings forth a very important message that, especially in the upper eyelid, if there is deflation, which is very commonly seen, inflation is what has to be done, not excision. So very new surgeons especially get tempted to remove that fold of skin, which can lead to further hollowing. So inflation is the key while rejuvenating the upper eyelid. And you have pointed it out really well. Especially in one case, I have seen that deflation sometimes occurs also because of detachment of the levator muscle. So sometimes even correction of that microtosis rolls the muscle outside and corrects the hollow along with a filler injection. That also might work well in such cases. Any comments from the audience? Any questions or any comments from Dr. Esam?
We can inject fat, okay, not just fillers, but so fat is an option, especially in patients because of fillers might have a bad reputation in the upper lid and with the danger of arterial occlusion. So fat injection might be more appealable to patients.
That's very correct, especially the nano fat or the micro fat.
The nano.
Especially when we initially used just a fat filler, we ended up with some lumps and bumps. So now most of us prefer the microfat more than the nanofat because microfat also contains the stem cells. Any questions, or we can take up 2 questions?
My question is to you only, Dr. Kasturi. Very interesting talk, and as usual, you come out with interesting ideas every time. So it's always a pleasure listening to you. So you spoke about biofiller and use of solid plasma block as a biofiller. But I believe in your talk, like what you stressed out primarily, that it was used as a healing substrate and material which promoted the vascularization. So have you tried using it only as a filler, just for augmentation? Like in the dimple which was there, you did other things also, and then you supplemented it with the block of this plasma. So have you tried using plasma block, whether it promotes the invasion of tissue extra or how long it lasts, like any experience about that?
Yes, very recently, like I was mentioning, this by PRF, you can have as a liquid and as a solid. Now we have something called semi-solid. The liquid we use for the neocollagen synthesis, solid as a filler, and also for the healing process. But the semi-solid, the PRF, the liquid that you get it, you can centrifuge it. Sorry, you can refrigerate it. Once you, nowadays we get centrifugation machine along with the refrigerator. So moment you take out from the centrifugation machine, you put in the refrigerator, you get a semi-solid form. That can be used as the same hyaluronic acid filler, and I believe many of the dermatologists are also doing that. So we have just started the procedure, and this will be a very good alternative for Indian scenario because hyaluronic is costly, number 1, with some complications, but this also leads to collagen synthesis. So I have shown, I think, one very small clipping where we use it now as a semi-solid filler.
Okay. So we need a study, I think, wherein we can get some idea
Yes.
about the duration it remains there and how much it promotes the actual.
Yeah, mainly I think with respect to repetitiveness, how often do we need to repeat it and how long does it last, I think.
Correct.
Yeah,
It
the
will be
one
interesting
that
to see
I'm
that.
using it, I'm using approximately 3 to 4 months interval because those are real bad hollows where they have a prominent tear trough and also shadowing effect, the hyperpigmentation. So I'm trying to follow up, just started with the semi-solid.
Thank you.
Yeah.
If no other questions,
Dr. Nair, I just wanted to ask.
Akshay is left. I
Akshay,
think.
you're here?
No, he's left.
He
I
just
I
left.
just, he said that he prefers a blade over radio frequency knife with cutting. So anybody can give
For
an-
the skin incision,
Yeah,
we
yeah.
all prefer blade because I feel the healing comes very good. But radio frequency is a good option. There was a publication in one of the OPRS journal where they did not find any change between the
Yeah,
blade and the radio frequency. But personally, I feel an Indian scenario where we have so much of scarring and pigmentation. So I usually also prefer giving first incision blade and then the subcutaneous I start doing either the electrocautery or the radio frequency.